Good afternoon, or good morning, as the case may be, wherever you are, and welcome to the 20th CVMA Veterinary Town Hall series on navigating through COVID-19. I'm Louis Qantas, the president of the CVMA. It seems like our travel through pandemic land has taken some interesting twists and turns with some disappointments, and each turn with its own challenge. And our journey continues now, only with a little bit more light, and it seems a little bit more hope in people's eyes, though still a lot of angst about what might happen next and what that might mean. So our Town Hall series will continue on an as-needed basis. And we thank Dr. Scott Weiss for being with us again with provision of additional up-to-date information and advice for veterinarians in Canada. Now, I keep saying every time that Dr. Weiss hardly needs an introduction, and so today I'm going to presume that you already know of his work as a veterinary internist and microbiologist, his positions as professor and other work at OVC and University of Guelph, that he's a diplomat of the ACVIM, about his Worms and Germs blog, and his many accolades. But just to add to his resume, to round it out, you might say, I'd like you to know that he also coaches under 18 women's hockey, which says a lot. And he's also the only person I know who has performed CPR on a pygmy hippopotamus. Now, you'll have to ask him how that worked out, but I'm guessing you might first want to hear about COVID and variants and progress on that field. So like always, please keep yourself muted with camera off in order to have the best online experience. And if you do have any questions, please feel free to type them in the chat box at any time for Scott to answer. So thank you, Scott, and virtual floor is yours.
Great. Thanks, Louis. Let's get some slides about it. So yeah, as per normal, toss any questions in the chat as we go. We'll try to answer all the questions that we get. Couple themes for today. I guess one is just a really quick update on a couple animal things. You know, the animal stuff has really been kind of status quo in terms of like the clinical aspects and risks in clinics. We'll really start thinking about other species as the concern. Most of the focus really is me where we are with Omicron and potentially beyond. So sorry, just going to make sure I've got the chat pulled up here. So yeah, we're still in the Omicron era. Yeah, we're going to be in the Omicron era for a while. I think last time we did this, we were really in the peak Omicron and we're trying to see which way it was going and hoping it was going to start to come down. And we've certainly seen that. We are seeing a lot of good indicators of declines in cases and hospitalizations and ICU stay. And I'll toss some numbers up from Ontario in a minute, but Omicron is still going to be here for a while. Now, one of the questions we have is what's next? Now, Omicron came out of nowhere. Delta kind of came out of nowhere. And what else is going to come out of nowhere is still the question. So as we get into new waves or new concerns, we've got two things that can happen. One is we can just get evolution of the strains that we have right now. And the other is we can get something that comes out of left field, like Omicron did. It really surprised us. It was genetically very different. It was probably circulating in an unsurveyed population where there wasn't a lot of surveillance, and then bang, it hit. Versus we can see things that kind of drift over time. We talk about drift with influenza, and we can have some of that happening as well. And right now, we don't know what's going on with Omicron. Well, we know a bit what's going on, but we don't know what's going to happen based on that. These are some data from the US, which basically show the purple bar here is Omicron. And then the lighter stuff up here is what you might have heard BA2, which is a friend of Omicron, relative of Omicron, whatever you want to say. It's an evolution of Omicron. So it's not this big shift, but we typically see is when a new variant comes in, if it's a successful variant, it really displaces the previous one. Delta displaced what was there before. Omicron's really displacing Alpha. And are we going to see something with this new variant? And BA2, we don't know a lot about it yet because it is fairly new. It does seem to be more transmissible than Omicron, which is somewhat of a surprise. We were starting to wonder whether Omicron was getting about as good as you can get in terms of transmission, and good being bad for us. But it's a highly transmissible virus. BA2 seems to be about 1.5 times more transmissible. Now, what does that mean, right? Is it just a more transmissible variant that's exactly the same thing otherwise in terms of severity and reinfection and everything else? We don't really know. And we're getting, I think, some mixed signals from different countries, and what's going on in different countries can be hard to interpret sometimes because their vaccination coverage, their previous infection rates, a lot of other things are different. And where they are in the state of their restrictions really has an impact too. This is an example that we see a lot mentioned about, which is Denmark. Denmark backed off on their precautions not too long ago. And one of the reasons was the public was just fed up, basically. The public was willing to tolerate more risk, and they were fed up and they wanted to move on. And they had a highly vaccinated population and a healthcare system that was, stable enough to handle an increase. But what we've seen since then, and obviously very recently, because where the numbers start going up just in the last few days, is a massive increase in cases. So new cases, and concerningly, going up in hospital admissions. Cases are still interesting and relevant, but it's the impact on the healthcare system, and it's the ultimate health impact on people that are the concerns. Hospitalizations shot up, deaths have shot up, and deaths tend to be a lagging indicator. So we see them increasing later than we see the hospitalizations. So this raises some concerns, but is this because BA2 has come in there, because it has, or is this because they've opened up too soon, too much? Or is it the combination of BA2 plus opening up? We don't really know, but it's a bit of a cautionary tale. And I think it's just a warning that we can't, try to either surrender or say we've won too quickly. Most places that have done dramatic changes in their protocols and in their non-pharmaceutical interventions have seen increases. So one of the things we have to do with a variant like this is really give it time, because you can't predict what it's going to do in our population. But we certainly do have some concern. This is why there's hesitation when it comes around to opening up fairly quickly, because we're in a phase where there's flux, because we had some changes, we've had some loosening, and we've got a new variant-ish that's come in, or variant of a variant. And we need to see how all those things settle out ultimately. But I'm going to divert to the animal side just for a couple minutes, and then I'm going to get back to the status in humans, which will come into some things on rapid testing, which I think is quite important for us. Some other things about vaccination, just general thoughts on that, and where we might be heading. So we've talked about, excuse me, this a few times, is deer. So we know this virus has gone into deer. We know deer are quite susceptible, and somehow we do a really good job of infecting them. And we've got positive deer in at least 3 different provinces where it's been identified. Just recently, just earlier this week, there was a preprint that was released finding Omicron in New York, Long Island. And, it really wasn't too surprising. So as we've seen the different variants, that's what we're exposing animals to. We do a really good job of spreading this virus person to person, and we do a really good job exposing animals. And some of these animals are susceptible. So cats and various things, but we don't really know how that changes through the different variants. And the only way we really find out is by seeing if they get infected. So we have a lot of information on experimental studies of different species, but most of these are with old strains that are not relevant. We don't have much information on Omicron or even Delta or even Alpha. So some of this is just ongoing surveillance, some of this is field work. So it wasn't too surprising though to find Omicron, because if that's what's circulating in people, then that's what we expect to see spilling into deer. And like the other studies, but in the US, they found it pretty commonly. The seroprevalence rate was pretty high, and the PCR positivity rate, which indicates, active or a very recent infection, was pretty high too. So, we've done a good job of infecting them. Deer spread it around. Now, for me, in some ways, I kind of sell this as maybe not really a good news, but in some degree, a good news story. Like the thing that makes me the most comfortable reading this is it's Omicron. Like I fully expect to find deer that are infected in any place where you've got deer in proximity to people. And what I want to see is it's a variant that's in people right now in that area. So if you look at in the deer we had in Quebec, they were infected with Delta, and that Delta, the sequences that Delta matched up really nicely with people actually in Vermont or anything else, I think it was. So it reflects that direct spillover. So we're finding Omicron in deer right now. Omicron's only been in people for a little bit of time. That's good. That's that close kind of reflection. Where I'd be worried is if we found Alpha or something else, right? Because if we found Alpha in deer right now, Alpha hasn't been circulating significantly in humans for months, many months, coming up a year. So if we found it in deer, that would suggest it's been circulating in deer for months. If we start finding Delta when Delta is really waned in the human population, then I get more concerned. Or if we start to find variants that are different. So you find Omicron, but it's an Omicron that doesn't match up with what we're seeing in people, that would suggest it's evolving. And that's what we need to sort out, because the big concerns we have with deer really are twofold, really. One is, are they a reservoir? Are they a source of infection? So we infect deer, and they keep infecting deer to deer to deer to deer, right? Because there are a lot of them, and they're gregarious species. So there are opportunities for transmission. If they do that, then maybe they keep circulating the virus. And as things wane in people, we have an animal reservoir that might become more relevant. Right now, an animal reservoir is probably of limited concern because you're much, much more likely to get exposed to this virus from a person. But as the human risk goes down, if we create animal reservoirs, the relative risk of them goes up. So that's why we don't want it into wildlife. So as things start to get under control, we've got something else to deal with. So one of the concerns is what's going to happen over time. So in the perfect world for us, if we're infecting deer, if we have to have deer that are susceptible, it gets into the deer, it spreads around for a short period of time, and then it dies out. So yeah, there's some risk of exposure for people that can contact deer in that time, but it's not going to be maintained there. And the other big thing we're worried about maintaining in the deer population is variants. So variants are random mutations. We've talked about this a lot. And they happen because of replication. So the more replication, the more transmission, the more chance of a variant. And when you do that in a different host, there's probably more chance of variants as they adapt a little bit for that host. So what we don't want to do is have this virus circulating long-term in deer, and you get these deer variants that emerge. Because deer variants might be good for us, right? They might be less able to infect us, but it's possible to go the other way. And we don't know. And really, the only way we're going to find out a lot of this stuff is time. So if we find Omicron still in deer in July, and Omicron's not the big thing in the Ontario population in July, then that's a concern. If we keep just finding these common recent human strains in deer, that would just reflect that we're doing a really good job of infecting them, but they're not doing a really good job of maintaining it, which is our best case scenario. So really, excuse me, we're at a wait and see thing here. We need to do more surveillance. We need to find out what's happening. And we just need to kind of wait it out to find out what the risk is. I'm just going to pop the chat here. So going to toss questions as we go. Any idea how they're being transmitted from people to deer? Yeah, that's the question that comes up all the time. And there are a couple possible possibilities. The biggest one is human to deer. So we might think, deer are wildlife, we don't interact with them much, but a lot of people do, especially in areas where you've got really big populations of urban, suburban deer. It's not hard to find lots of videos of people hand feeding deer. I've got deer all over the place. I just live outside of town. I see deer tracks within like 10 feet of our house. If I started putting corn out, they'd be on my front step, and I'd be able to hand feed them probably pretty easily thereafter. So that type of encounter certainly is a possibility. So that's probably the number one, is that direct human exposure. I don't think we can discount the possibility of animals. It's really not hard to find people talking about their animals having close contact with deer. Lots of videos of cats. Cats are quite susceptible to this virus. Cats can transmit it cat to cat, so they presumably could transmit it cat to deer. So if an indoor-outdoor cat gets exposed and encounters a deer, especially a fawn, then that's a route of transmission. I was doing a talk for a shelter group an hour or so ago, and a person was talking about how their dogs go nose to nose with deer all the time through the fence line. Well, dogs aren't a very susceptible species. They may not be able to transmit it, but it just shows that potential animal bridge that could be involved. The other one that comes up is wastewater. Wastewater is probably not a big risk, because even though we use wastewater for surveillance, we're looking for snippets of DNA or RNA. We don't know that there's live virus there, infectious virus there. So wastewater is probably well down on my list, but it's not a zero component. But most likely it's direct human deer contact. But if you look in the US, the rates are really high. So there must be a reasonable bit of human deer contact, plus they spread it really effectively between themselves. So that's all I got for animals. But if there are any other animal questions, obviously toss stuff in the chat. I can go back to any of the animal content. We can talk more about it, since obviously that's what we do. Actually, there was one more animal thing. Sorry, one more animal thing. Hamsters. This was a big one that came up a while ago. A couple weeks ago. And the story revolved around Hong Kong. So Hong Kong has a COVID-0 approach. They have a very aggressive approach towards infections. And they think they have a good handle on it. I'm not convinced it's quite as well controlled as they think, but they have a pretty good handle on what's going on there. And to make a long story short, they found an infection with Delta in a person that worked in a pet store. And they also found another infection with someone who'd been to that pet store. And there was a common link of handling hamsters. My initial thought was, okay, well, that's just human transmission. And they just didn't know where that first person got Delta, because there's some background noise. But when they looked into it a little more, they found the hamsters were positive. And again, okay, let's just think that's probably human to hamster transmission in the pet store. But when they get more investigation, there is a hamster side here that I think is relatively solid. This is a preprint. I've reviewed the full paper, and it actually is pretty solid. So what they've got is they've got two people or a couple people that are infected linked to the pet store, and they had some positive hamsters in the pet store and in the facility that supplied the pet store. And the movement was from the warehouse to the pet store, not the other direction. So, it looks like it probably came from hamsters in that facility, went to hamsters in the pet store. Now we've got two people with the same strain in the pet store. So that does fit with the hamsters being the source. And, here's where we get a little bit jaded because China's tried to blame other countries for bringing the virus in, but there may be an importation component here too, because the Delta variant that they're finding in the hamsters is consistent with what's found in Europe, in the Netherlands. And hamsters were imported to that facility from the Netherlands. So here's where it starts to get a little bit of a weaker link, but there certainly is a reasonable story here where someone infected hamsters, or hamsters are somehow infected in the Netherlands. They're shipped to China to this warehouse holding facility. They went to the pet store, and then they passed it on to a couple different people. So quite an interesting investigation. Now, the response was something that I think is over the top. So the response was to kill anything small and fuzzy, basically. So they went through and they tested a lot of hamsters and a lot of other small mammals, and it was just hamsters that were positive. But they decided to euthanize all the hamsters and all the other small mammals associated with that. And they put out a call for any hamster that was adopted within a month before. They wanted people to bring them back so they could euthanize them. So there was kind of an underground hamster rescue going on, trying to move these critters around, despite the risk being very low. Like a month before, if the hamster was infected, it's not infected now. So there really wouldn't be a risk there, but that fits with their kind of aggressive COVID approach, and the whole best way to get rid of an animal problem is to get rid of the animal. So, but it just, again, another instance showing a little bit more potential for animals to be moving this virus around and sending this virus back. Now, again, this was Delta, so this is a human strain. There's no evidence this was circulating in a hamster variant, but, human to hamster and back to human in this type of situation. Okay, I'm going to present some data just to kind of give you a frame around where we are, because that lets us think about where we're going, whether it's clinic operations or just life in general. But I'm going to pop over the questions for a sec. Case numbers don't seem to correlate with public health measures. The problem is we don't know what case numbers are because surveillance is always just part of it. We always only get some of the cases. But with the decreases in testing in a lot of areas, and Ontario is classic for that, we don't follow it as well. Certainly, there's good data that the non-pharmaceutical interventions work. They all work a little bit. There's no magic bullet. Masks aren't a magic bullet. Hand hygiene is not a magic bullet. All these things aren't magic bullets, but they have positive effects. And when you layer them on in that Swiss cheese approach, you get a net positive effect. But that's the problem. And it's the problem with anything we do in infection control, because usually when we're intervening, whether it's an outbreak, farm or a clinic or a pandemic, we don't tend to do just one thing. We tend to do a bunch of things, and we see if our package works, right? And if our package works, great. We don't necessarily start saying, well, what if we do this combination and that combination? We base it on some general principles. And with COVID, the advantage is over time with variations in how things are done, we can tease out a little bit more how effective are masks, how effective are different things. So we do have a lot more information now than we have in the past about the relative impact of these different things, and with masks, the relative impact of different masks. They're always vary a little bit geographically. So I would say the short answer to that is the public health measures work. They all work a little bit. Some work better than others. How well they work will vary a little bit with what's going on, what strains there, and in the situation. But there's not that you can't come out and say that if you do this one thing, you're going to drop your cases by X%, because it's too variable. Another question there: what about a client that uses a rapid antigen test on their cat and it's positive? So this brings in two aspects. One about rapid tests in animals. The other is positive animals. Okay. So we know very little about rapid tests in animals. I know cases like this where someone's tried it on their dog or their cat. So what I would basically say is a negative doesn't tell me anything because I don't know the sensitivity of the test. The positive is pretty convincing. So if you got an exposed animal and it's positive on a rapid test, there's not really any reason to think there should be something about a cat that's going to make false positives happen. And false positives aren't very common with the rapid tests. So I don't advocate people doing it because I don't know what to do with the results and I don't want to waste the tests. And really, for your average person, knowing if their cat is positive or negative doesn't have a big impact on what we would do. But if someone does do a rapid test and it's positive, I'd say, yeah, odds are very high the animal's infected. And, getting to the point where, they're probably fairly high the animal's infectious, because you have to have a pretty big burden of virus to be positive on a rapid test. So they've got a pretty good viral load. Now, what do we do? Well, the test doesn't mean the animal should come to the clinic, and the test really means the animal probably shouldn't come to the clinic. So if someone calls up and they've got a cat with a positive rapid test, like most cats that have positive tests aren't going to be sick, or they're going to be mildly sick. So it really comes down to the degree of clinical illness. Someone calls up and they've got COVID and their cat's been sneezing and it's been a little bit lethargic, and they did a rapid test and it's positive. It's like, okay, well, keep the cat at home, right? You stay home, keep your cat at home. I'm not going to do anything. Like, your cat sounds stable. What am I going to do when the cat comes in? Nothing. I'm going to look at it and I'm going to say, give it some time. If the cat has pneumonia, and it really comes down to the clinical status. So if there's a clinical need to bring the animal into the clinic, regardless of what the positive result is, then we need to think about the risk to the cat. So they call up and you've got this cat and it's respiratory distress, and it's positive on a rapid test. Okay, well, I'm going to consider this animal infectious when it gets here. We've got some guidance on our OVMA document there, but really it comes down to a cat with respiratory disease from a positive host and a rapid antigen test. Okay, it's biohazardous. So I'm going to want to wear all the PPE that I have. I'd prefer to have an N95 or a KN95, eye protection, gown, gloves, handle it in isolation, keep it separate from other people, and get it home if at all possible. And think about aerosol generating procedures and all that. And potentially call someone like me if they want some guidance on it. So it's part of the puzzle, but just because they're positive doesn't mean we have to do anything different. It really comes down to the clinical status, because most of the time these are going to be clinically irrelevant, or not going to be make or break clinical data on these animals. Okay, I think we're caught up on questions, so keep on tossing them in though. I'll keep going back to that. So these are Ontario data. It's from the science table. So as I mentioned before, we put these out every couple of weeks. And it's been really, the modeling discussions have been really interesting the last month, because they're hard, because we don't have the data. And we're relying on data where there's less confidence by having to bring in other types of data sources to kind of finagle a model. And I'm glad I'm not a modeler. I just get to see them and comment on them. But we do have some good indicators. So I mentioned wastewater. I'll show a slide about wastewater later on. Wastewater has been pretty good as a proxy, because if more people are infected, they're pooping out more virus. And wastewater does tend to correlate pretty well with cases. Now, wastewater has some limits, and we don't test every place. We don't test every person. Obviously, it's composite. We don't get areas that are on wells. We don't have surveillance in some areas where there's not someone to collect. But overall, it can give you a fairly reasonable idea. And with the wastewater sampling, it looked like things really started to peak early January. And that fits with test positivity. So test positivity, even though our test numbers went down, we can look at the positivity rate to give us an idea of what's going on, and test positivity kind of mimic that. So I think where we are in Ontario, and I think it's fairly similar in a lot of areas where we had the Omicron wave, shifted by a couple of weeks potentially, but we've passed our peak for this wave. Now, what's going to happen in the next 3 weeks is the big question, but we passed our initial Omicron wave. And a lot of that's been mobility. So mobility gets monitored through various things, in transit, through spending. So you look at restaurant and retail charges and things like that. And our mobility has stayed, has come down. If we look in the fall, it was fairly high. If you look at retail and recreation, mobility is pretty high, and then it plummeted around December. And that's probably one of the reasons we didn't have as much of a wreck as we could have, because people were decreasing their contacts. Okay, so I'm just going to put some text on the top of my screen. I'm not sure why that's there, but it doesn't really matter. Okay, so cases are one thing. I've said this a few times. It's the strain on the hospitals that is the big concern. Canada has one of the poorest acute care hospital capacities in the developed world, and Ontario is on the lower end of that. We have fewer beds per capita than a large percentage of other developed countries. So we don't have surge capacity. And that's one of our problems, right? We've had to limit a lot of procedures, and there are a lot of people that are going to have worse outcomes or die because they couldn't get required cancer treatment, heart surgery, and everything else, because our limited hospital capacity was full. So this is one of the big metrics that we pay attention to. And also obviously for the severity of disease, just the morbidity and mortality in affected people. So we had a big increase, obviously, with Omicron. That's come down. It's come down more since this graph. So we are seeing a nice decrease. I think we're around 2,000 now in hospitalizations. Deaths tend to linger a little bit more. It's against a lagging indicator, but they are coming down. Just put this up to talk about the kids side. So hospitalizations in kids are still a minority of the hospitalized population, but they went up, right? And they went up quite substantially. So if you look at the axes here, overall new admissions, you're looking at 200 here versus 10 over here. So kids are the minority. Like kids don't get seriously ill very often, but they can. And deaths are very uncommon, but they can occur, and they don't always have to occur in someone that has a comorbidity. And regardless, having a comorbidity shouldn't be a reason to dismiss a death or a serious illness. So there still is a reason that we're worried about kids. Rates are overall low, but hospitalization rates did go up during this Omicron bump. Now, vaccination, the messaging around vaccination gets a little bit tougher, and it can be spun in some bad ways. Vaccines still work. And what Omicron has showed us is vaccines, even though they get challenged by a new variant, vaccines still work really well for what they're mainly intended to do, which is keep people at a hospital and keep people from dying. They're not, we got lucky, we got spoiled early in disease, really. We got really excellent vaccines at the start. They did a lot more than we had hoped for, really. They were able to stop transmission really well and a lot of other things. Versus now with Omicron, it's been more of a challenge for the vaccines, but there's still a huge discrepancy between hospitalization, ICU, and death rates in people that are vaccinated. And this is vaccination of people with at least 2 doses, and that's not fully vaccinated. And that's a message we need to get around. And I'll show a slide, actually this one. So what we've seen was Delta, vaccines held up pretty well against Delta. So this is, if you can see if you can see my cursor here, the black dots, boxes, is vaccine efficacy over time. So you see from time of second dose down to 8 months after the second dose, not much of a drop, still around 80. We've kind of said 85% or so on average for vaccine efficacy for symptomatic infection with Delta. And then you get a third dose and it gets up, in the high 90s. Omicron's a different animal. So Omicron dropped, and by 8 months, you can see it's not doing a whole lot. So 2 doses and 8 months interval, you're not doing a lot for symptomatic infection. This isn't severe disease. This is symptomatic infection. But you get that third dose and it flies up pretty quickly. So again, this is a 3-dose vaccine. I think that's why I say it's 3-dose vaccine. That's the key thing here. Severe hospitalization or severe outcomes in hospitalization, again, excellent for Delta, still very good for Omicron, especially with that third dose. We're still getting, high 80s or higher with 2 to 3 doses. You do get some loss. The error bars on these are pretty big, so I'm not sure I'd put a lot of stock into that drop. But it is not quite as good as Delta, but it's still pretty good. And with a third dose, we get good protection. Now, one of the questions is what happens, 6 months after the third dose? We don't know because Omicron has not been around long enough. We're not anticipating this to be a couple times a year vaccine because it's not going to work that way. But it might be a yearly vaccine for a while until we get different vaccines or we see what happens epidemiologically. Just some additional modeling. Again, this is Ontario. I'm sorry, that's the main data that I have. It's from earlier this week. And just looking where we are now. So I said we're going to see a little wave. We're expecting to see a little wave because we reopened, and maybe reopened a couple of weeks before really was ideal. And our vaccination rates still aren't as good as they could be with that third dose. And we look at all the people that have 2 doses, right? And then got a great 2-dose vaccination rate. Third dose is still coming up. So I'm not going to go into the scenarios in much depth, but we've got our bump with Omicron. We've come on down. We're doing pretty well on the low end of this rate now. And what happens in March is going to depend on a couple of things, transmissibility of BA2, if it takes over, how many more people we get vaccinated, and how good recent infection protection is. And you can get reinfected very easily with Omicron. Previous infection is not a great, it's not a vaccination. It'll help, but it's not a vaccination. So we're expecting to see something happen kind of second week of March or so. Presumably won't be this red one. We're hoping it won't be, but somewhere in this kind of green to yellow range wouldn't be too surprising as hospitalizations start to come back up. If we back off on the non-pharmaceutical interventions, and especially if we do it very quickly, then you head up a little bit quicker. So we still have we're not out of the Omicron woods yet, but we've got some good indicators. And similar numbers with ICU. So ICU numbers come down nicely. We're going to see potentially an increase, fitted line in the middle here. Really depends on things like vaccination and the non-pharmaceutical intervention side. So we will see a bump, but we're hoping it's not going to be a bump that's going to, compromise capacity too much. I'll just pause here. I want to talk about rapid tests because it's still something I get like daily questions from clinics about, but I'll head to the chat for a sec. So toss in anything else you want there. So I guess we covered the human rapid test. So when I mentioned rapid tests in animals before, I was talking about the human tests because we don't have rapid tests for animals. So it's just people that are using the rapid tests that we have. How many of those COVID infections are incidental findings? So this is a controversial area because it's not really defined what incidental finding is. So if you say how many people are hospitalized in ICU purely because of COVID, right? They have COVID respiratory disease or they have a clot from COVID or something, 50 to 80%, depending on where you are and the data set. And then you've got a population that don't, but the problem is you can't just say, okay, you got 30% that are hospitalized with COVID. A lot of those are compromised by COVID. So if you're hospitalized because you have a heart attack and you get COVID in the hospital in particular, your outcome is going to be compromised because you're going to be sicker. You might get complications with COVID. You might be more likely to clot. You might have all these other things going on. So it's used somewhat as a deflection tool. But it's a relevant point, right? Because we don't want to overcall the impact of it. Really, it should come down to how many people are in ICU and their care is being compromised because they have a SARS-CoV-2 infection, right? So everyone that's hospitalized with COVID respiratory disease, and anyone that's suffering more complications or in ICU. So they wouldn't have been in ICU, they'd just be in a ward after their heart attack, but now they're in ICU because they're recovering from their heart attack and they got COVID secondarily. So now they're sicker. And it's complicated because getting that granularity of data is really difficult, especially on a daily basis. So there is a component there that it's incidental, but a lot of the potentially incidental ones really are COVID is playing a role in their illness. Okay, so this is a Ontario Science Table brief. This was just from yesterday, a couple days ago. If you want to see it, if you can just Google Ontario Science Table, you'll see the whole list of briefs, or you can email me. It's got a lot of good stuff in there. I've just kind of lazy and highlighted some of the key messages here, and I'll show a few slides. And these are really important because we are using these a lot in clinics, and we need to figure out how to use them. And they're a useful tool. Their use is declining because of some issues with Omicron, and just changes in the epidemiology of this pandemic. So one key thing, rapid tests are less sensitive for Omicron, especially the rapid tests that we're using in Ontario, especially early in disease. So if you're trying to use this to say someone was exposed very recently, I want to make sure they're good to go, don't have a lot of confidence in that. Even someone that's really early symptomatic, we might miss it. PCR positivity precedes rapid test positivity. And I'll show a little bit about that. So, that's not saying they're not useful, but what we keep coming back to is the positive predictive value is much more valuable than negative predictive value. A rapid test positive tells you a lot. You're infected and you're probably infectious. A negative means you may or may not be, and we need to look at the other circumstances. One thing about rapid tests, and I talked about this last time, is combined oral nasal sampling is superior for Omicron than just nasal sampling. And typically these have been pushed out as being nasal swabs. So if we want to optimize the sensitivity, we want to do oral and nasal. Typically that's a composite. So you do your throat or do a mouth, cheek, whatever composite your mouth, and then go up the nose. A single negative rapid test cannot rule out infection, kind of like I just said. So we can't use it as the green light. So you've been exposed or you're not feeling well, let's do a rapid test and say you're good to go. And Lee mentioned I'm a hockey coach. We deal with this. I'm director of development for our association. I handle all our COVID crap too. And just the other day, we had a kid that maybe had an exposure. We weren't really sure. She wasn't feeling well, and she had a negative rapid test. Okay, well, she's taken some time off because I don't have enough confidence in that negative rapid test. And we're in a high-risk situation where we got lots of kids together. They got mass op at times. They're on the bench. They're breathing heavily. So it's a high-risk environment. So we're more conservative. And I think we have to think about that at clinics. When you think about, okay, there are recommendations for isolation. So if someone has COVID, they can come back, depending on some rules, 5 days after the onset of their symptoms or their positive test. But that's the minimum, right? That's when you theoretically allowed to get out. And we know people are going to be positive at that point. And if they're going into a high-risk environment, we can be more conservative. And I consider clinics a high-risk environment because we have times when we get close together. So small animal clinic, you're working with someone close, you're struggling to put a catheter in, you're kind of face to face, and you're breathing heavily and you're talking. That's a pretty high-risk thing. You're on the road, you're going between farms, and there's a technician and a vet together in a vehicle. That's a very high-risk time. So we have to think about whether we should be adding on some extra time or extra precautions. And again, not relying on a single negative test to say you're good to go for something. But on the flip side, like I said, positive predictive value is really good. If you get a positive test, you're infected. Like, you'd be pretty confident about that. Assume you're infected. Do you get a PCR test? You could. Why? Really? It's not going to change, really. At this point, at the start, it was recommended you follow up with a PCR. Now, we know that a positive is a pretty solid positive, and it's kind of a waste of capacity to go in and get a PCR test. So typically we're not. The main question that's kind of coming up is the value of PCR documenting this really is thinking down the future, because we don't know what this is doing to people, right? We know most people get over this. You survive or you don't, but you get over it. But long COVID is still a pretty significant concern. And we don't know what that's going to mean, 6 months, a year, 10 years down the road. And like, the main value of a PCR test is you have a positive test in the medical system in case there's a workman's comp issue or a disability issue, knowing that you've had previous confirmed infection versus a rapid test. So I'm not saying people should go get a PCR test because they're worried about something down the road, but that's where you see most of the discussion about talking about follow-up. So we might potentially see more PCR testing because of that, but it's a capacity issue. And it also means you have to leave the house. Creates exposure, creates public health drain when they could be doing something else like vaccination. So rapid antigen tests have a role, but we just can't overassume what they do. So these will just support some of the things that I said. So the sensitivity, so the percentage of positives that they'll actually pick up. These are the two of the main ones we use in Ontario. So you can see that, they're not great. Just single nasal swabs on, I think this is all nasal data, but it drops with Omicron versus Delta. So it's not useless, but standard Q, you got sensitivity of 20-some%. You're missing a lot of positives. So again, don't rely on a single negative to tell you anything. And then the time thing comes in here too. So as I said, PCR positive, PCR is more sensitive. And as this test becomes less sensitive, you get even more separation of PCR and rapid tests. So days from your first PCR test, even 2 days after your first PCR test, sensitivity is below 20%. And you get up to 4 to 7 days after, it gets really high. So again, that negative result, that early test, isn't going to be overly valuable. So don't push doing rapid tests really early after exposure because you want to get someone back to work quickly, or you want to go to a party really quickly. You need to give it more time to have more confidence, and you need to do more samples. And I think the next slide maybe has that. This just backs up that throat nasal versus nasal only for Omicron. So combination swab, which are easy to do. So we can do the throat and the nasal just as easily as a nasal. So if we're worried about Omicron, do the 2-site sampling. There is a video, Science Table put out a video on YouTube. It's pretty straightforward, but if anyone wants to see how to do it, it's there. Now, one thing that's come up is how to use testing in terms of, let's just try to keep it out of our clinic. So earlier on, when rapid tests were available and it was Delta, we were starting to think about, okay, should we do periodic testing? Right? You test once a week or whatever. The university's done some of this with the animal health lab. So it's weekly testing. And if you're positive, you go home. And what we've kind of found out over time, the yield of that is pretty limited, because you've got to get them in that right window within a week. And you can be negative right now and positive, that afternoon or tomorrow. So bang for buck goes down. And when you don't have a lot of tests, for the last couple of months, I've really been telling people to conserve their tests and not be doing as much routine or any routine stuff, and save them for high risk situations. So save them for people when they've been exposed. Or if you're going to test 5 days of isolation, you want to do a pair of tests after their 5-day isolation period, that's where I'd rather see it, because it's going to have more impact on what we do. And this kind of backs that up. If this is looking at university unvaccinated college students, where they looked at frequency of testing and how many cases they would miss or identify. If you test once a week, it doesn't do much. Again, you've got that, you're looking at a very short-term window over the course of 7 days. If you test 5 times a week, you'd be pretty confident you're going to pick them up and then stop downstream transmission, ideally. We don't have enough tests to do 5 times a week, and most people aren't going to tolerate doing 5 times a week. So there kind of is a sweet spot in between. We're testing a couple times a week. So if you're going to do testing of your staff and you say, we're going to do random testing or test everyone just to make sure we don't have this sneaking in, you need to be thinking about doing it a few times a week. But really, unless you have a lot of tests and a really compliant staff, I'd be more saving my tests for the high risk situations. So someone's gone away, someone's maybe been exposed. If it's a really high risk thing, we just don't want them coming in. So we're not using a rapid test to clear someone that we're really worried about. We're using a rapid test as an extra layer of security and using it after that 5-day isolation period, because that 5-day isolation period is still pretty dodgy for high level of confidence. Just one more thing about wastewater, just to be curious. So at the university, we do wastewater surveillance for our residences to get a signal, because we can't test students all the time. And when we see signals going up, it gives us the opportunity to intervene, so educate, encourage people to get tested, things like that. Just if you're interested in seeing the data, there'll be a new dashboard coming out fairly soon that's going to have more numbers and graphs and stuff. But this is something that going forward, you're going to see more of. I mentioned the kind of first couple slides that this is giving us a good indication what's going on in Ontario. And we may see this used in a more targeted manner. It's not something we're going to do in every facility, obviously. You have to have access to places, you have to have access to a manhole cover that drains the area you want, and you have to have testing capacity. But over time, this may be one of the things that we use to get a general idea of what's going on and to see if there are new variants coming in, as well as you can test for other things. You can test for influenza and a range of other infectious diseases. So I'm going to pop back to the chat now. So if you have questions, toss them in there. As ever, if you have any questions, email me. If it's something urgent, toss urgent in the title so I can get to it quickly. Let me see where we are with questions. This week in the town, you can pick up 5 free boxes of rapid antigen tests. What's the rationale for it, and when should we use it? So basically, it's kind of what I was saying a minute ago. I think getting them is good, and you want to use them in higher risk situations. What you don't want to use them, like if you're sick, if you have signs that it could be COVID, assume you have COVID. Sometimes you see there might be value in, you've got like other times a year can be a little bit more useful. So you've got seasonal allergies and you've got typical allergy like signs, but you want to be convinced. So here's where you'd ideally do a couple rapid tests. So you do a rapid test today, you do a rapid test tomorrow, and you figure you're not likely to have it based on your clinical signs, and your 2 tests back that up. Now, if you've got fever, chills, myalgia, things like that, we don't tend to see the loss of smell and taste with Omicron. You see more flu-like signs, including just things like myalgia. So if you've got clinical signs that would fit with an Omicron infection, just assume you're positive. And if you want to test, you want to wait probably a couple of days again, or do a series of tests, because if I just start to feel crappy today, I may not be positive on a rapid antigen test yet. So I think where the biggest value, really, the clinic operations standpoint, is in a couple of situations where maybe you've got someone that went on vacation or did something high risk, and you could get them to test a couple times before they come in. Or, even if they're working, get them to test a couple of days, you got a little bit more notice, have them do more intensive practices. Or the big one, someone's been infected and they're allowed to come back at day 5. If you're doing that, I would pump it to day 6, but have them do a rapid test on day 5 and day 6, or do day 4 and 5, but get a pair of rapid tests before they come back in. And, the pair of negative tests in someone that has had COVID, right? So they're on the downward swing of their viral load. It's probably gives you a fairly high level of confidence. It's not a guarantee, but it's a pretty high level of confidence. Should we still be wearing N95 or KN95? Yeah, absolutely. Cloth masks should be completely obsolete. At the university, we've kind of banned cloth masks. We require medical type, so medical or non-medical, kind of the flimsy masks, or ideally N95, KN95. So my message is use the best mask you can get. KN95s are really easy to get now. They're actually as comfortable. I find the KN95 is actually more comfortable in kind of working situations too. So we wear masks. So coaches on the ice, we wear masks for our association, and I'm skating with some pretty high level, 17, 18-year-old kids. So I have to work my butt off sometimes, and I'm sweating a lot. And if I wear a surgical mask, it's a lot harder to work actually, because the mask gets stuck and you're breathing in. A KN95 makes it much easier. So if you're working in an environment, you're worried about, how hard the mask is, like some of the more structured KN95s that don't suck into your mouth and nose work. The Canadian women Olympic team showed that. They played a whole Olympic game in KN95s. So KN95 and then N95, FFP2, any of the higher filtration masks, I would absolutely use them if you can. The surgical mask will help, but we've got data from CDC just from the last couple of weeks released that's showing again superiority of the better filtration masks. And it makes sense because this is a more airborne pathogen. The original strain, we were worried more about droplets. So the surgical mask, cloth masks were protective there. They're just not going to be as protective with a strain that's just transmissible. How long after a person is not contagious anymore would they still test positive on a rapid test or PCR? For a rapid test, like the general assumption is like the threshold for where you'd be positive on a rapid test is, well, maybe pre-Omicron was about 100,000 copies per mil. And that's kind of around the level someone's infectious. So the assumption has been with Delta that if you're positive on a rapid test, you're infectious. If you're negative, you're probably not, or you're lower likelihood. Omicron, we don't have that data. So we don't know as much about it. But with a rapid test in terms of duration of positivity, you know, you tend to get positive and you tend to get negative fairly quickly. So if you got someone that was positive on a rapid test and now they're negative on a rapid test, odds of them being infectious are pretty low, and that's going to happen pretty quickly. PCR is really hard to link up with infectivity unless you get the crossing point value, CT value, which the labs, you know, typically report back. So what that gives you is a semi-quantitation or a quantitation. So PCR can be positive for a long time, which is why it's not a good tool to say if someone's infectious, because you can be PCR positive potentially for weeks in some situations, even though you're shedding a really low level of virus or dead virus, and it's not clinically relevant. So they're kind of in between. Rapid antigen testing is much better to tell you whether you're infectious or not. With Omicron, we probably lose a little bit of that because we probably miss some people. They're still a bit infectious, but overall, if you're negative on a rapid test at that individual point in time, you're probably relatively low risk to be infectious. If you're positive on a rapid test, you're probably quite high risk of being infectious. And if that didn't clear it up, Louis, let me know. I can answer it better maybe. Assuming most clinics are still mostly curbside, what indicators start to let people in? That's tough. Like I kind of gone over that before. We got a whole list of things. It really comes down to your clinic. So it's thinking about, well, what's the epidemiology in your area, right? How much risk do you have coming in? So what's the risk of someone bringing it in? What's the risk to the people in the clinic based on their vaccine status, their health status, and what can we do in the clinic? And how does being curbside affect clinic operations? And it really varies, right? So if you've got everyone's triply vaccinated, everyone's young and healthy, no one's got high-risk people at home, you might be more flexible and more kind of aggressive in your opening. If you've got a clinic where you have lots of space, and you have really good ventilation, and you got HEPA filters, and you got CO2 monitors, and you're able to not have clients, you know, gathering in the waiting room, you're able to space them out, put them in exam rooms, you can probably open up more. If you got operations such that, you know, you can do a lot of stuff in the back room, so you don't have to go into the appointment with the client. So they go into the exam room, you take the animal in the back and you do your thing. So you limit the mixing, you can bring them in sooner. Depends how much space you have to store animals, right? Curbside requires more animal handling, you know, holding facilities. So there's not an answer for every clinic, but you have to think about what are the odds someone's going to be bringing the virus into the clinic? What are the implications of the virus coming into the clinic to my staff? How much of a benefit is it to open up, and what can we do to mitigate that? So if you're in a clinic where it's just really, you're cramped already, you start bringing people in, it's a lot harder to mitigate the risks. So I would wait longer than, you know, a nice big spread open clinic with great ventilation and operations where you're able to do things. And part of it is your willingness to step it in a little bit. So people can come in the clinic, but you're not going in the exam room with a client, or you're only doing this, that, and the other thing. If you're able and willing to enforce that, then we kind of baby step our way back in. And I think the thing to consider as well is hybridizing this anyway. The more we can do curbside, like curbside can actually help, for depending on your clinic, right? Curbside can increase efficiency in some ways. So partial curbside where you've got drop-offs, you can kind of squeeze in wherever without bogging up your waiting room, without requiring as many exam rooms, using some telemedicine for things that you don't need to see the animal, or you can do the telemedicine appointment first and do the quick exam like the puppy vaccine after you've done the long consult. It lets you keep people out of the clinic, and maybe lets you keep some vets out of the clinic too if they're doing telemedicine from home. So like I said, there's not a really straight answer to that question, but those are the components that I would think about when you're deciding. How long a PCR test may remain positive after infection? Well, this is variable. Usually it's going to be, days to a week or so. But some people will be positive for weeks. And sometimes it's immunocompromised. They're not kind of clearing that last little bit of virus. Some people it's just strange. And this is my big concern. Like, I'm not accepting any international travel because I don't want to be in a situation where I go to the US and get infected and I need a negative PCR result to get back on a plane. And I'm just one of these that's, positive on PCR, even though I'm not infectious, for a couple of weeks. But most people are going to be a negative PCR within 10 days or so, I would say. I'm not sure, I haven't seen really good Omicron data lately, but it can take a little while for PCR. Recommendations for triple vaccinated worker with a positive double vaccinated child. So, vaccination is very good for preventing severe disease. Vaccination is not as good for preventing infection. Triple vaccination helps. We don't have much data on that just because of the lag of getting the data with when Omicron hit and the number of vaccinated people. So, I think vaccine status reduces the risk someone's infected. Vaccine status doesn't mean that you can say, okay, that person is not a concern, they can come to work, versus if they weren't, I'd do it a little bit differently. So if you have a triple vaccinated person, doesn't matter the vaccination status of their child to some degree. If they're positive, there's a risk of exposure. So it depends on where you are. But if you've got a household contact, typically you're going to be 5-day isolation based on that household contact, which, is a really narrow window, because if your kid's infected, it's saying you've got the same isolation period as your kid, even though you could have been infected 4 or 5 days later. And I'd be more confident in using that, kind of borderline approach if the person's triply vaccinated. So here, the kid's positive, so the kid's isolated for 5 days after they're positive. Technically, the person, unless they're working in a high-risk situation like healthcare, at least Ontario, is going to be able to go back to work. That's when I'd like to bring in the rapid test. So they're triply vaccinated. They've had that 5-day period. If you get 2 rapid tests on them, the odds of them being infectious are pretty low. Not zero, but they're pretty low. Did I miss any questions? Are we good? Any last questions? Feel free to toss them in the chat there. We might be done before 1:30 for a change.
Yeah, well, if there are any fast typers that have other questions, well, Larry, you want to answer that question?
The truckers prevail. I'm going to shut my mouth on this.
Okay.
I got enough lawsuit threats. I don't need one more.
Okay. Well, there were a lot of questions answered, and we sure appreciate your time again, Dr. Weiss. Thank you very much. Thank you, everyone who participated today as well. And please, as we go from here, I encourage all of us to be brave enough to be kind to everyone we meet. Keep your eyes on your emails for potential future town hall virtual meetings, and keep breathing. Thanks, everybody.
That's for the hippo story in the chat. I'll give the hippo story for 30 seconds.
Yeah, go ahead.
Leave if you want. If anyone wants to hear the hippo story, it's a pretty short one. So I was doing an exam on a hippo, and it died in recovery. Basically, the question was, does it have respiratory disease? And we'd see the heart wasn't doing much, and it arrested during recovery. So we ended up doing intracardiac epi, because you can't really feel a pulse on those critters. So doing compressions, doing intracardiac epi. And the weird part of it was there's a camera crew there filming a show called Zoo Diaries where they're following stuff around. So what are you doing now, Dr. Weiss? It's like, what the hell do you think I'm doing now? So we're jumping on the chest of listening. So unfortunately, the hippo didn't survive, but it was an old pygmy hippo with heart failure. But that's one of my
there are some you can't win then, right?
Yeah, for sure.
Okay. Well, thanks very much for the update on the hippo too, and everybody have a great day.